Hello. Today, Elizabeth Clark and I are going to be speaking about ICD-10 documentation education for clinicians. This is our condensed version of our 17 modules put together, and we're looking forward to sharing with you the key items that you should be looking at for the careful documentation that's going to be required in order to code with the greatest level of specificity. Elizabeth and I are going to be sharing and doing part of the presentations, each of us, so let's get started. First of all, for our disclaimer, please be aware that at no time are we stating that we are providing any kind of legal advice. This is purely for educational purposes. We're going to be talking about the differences in the number of codes, some of the similarities and differences in 9 and 10, the requirements in documentation for the greatest level of specificity, and some of the complexities and the overall impact on home health and hospice. So let's get started. Now this presentation will take us approximately 2 hours, and we're going to be talking about ICD-10, which goes into effect October the 1st, 2015. And of course, you know there's been talk about all kinds of delays, but we need ICD-10, and we believe that everyone is beginning to see that. So it is not believed that there is going to be any kinds of delays. Now, for the 60-day episodes beginning August the 3rd, 2015, the RAPs will be coded using ICD-9 codes, and the final claims that end October the 1st will be submitted with ICD-10 codes. Now, as most of you know, there are 5 times the number of codes in ICD-10 as there were in ICD-9. That's a lot of additional codes. Also, ICD-10 codes have 7 characters. And notice we said characters, not digits, because there will be alphanumeric. The first character is alpha, and a code is considered invalid if it does not have the full number of characters required for its specificity. Please keep in mind that some of you think that ICD is new, but actually ICD was developed in 1893 to collect data on causes of death. And ICD-9 has been around since the 1970s. So it's about time that there was an overhaul. And you certainly know that we really have exhausted all of the areas and expansion capabilities of 9. We really do need ICD-10. Some of the reasons why the specificity for documentation is essential, you can see in the structure of ICD-10 that the category of the code will be identified first. The etiology, the anatomical sites, and the severity levels will be followed, and then the extensions, and we'll be talking more about each of those areas. Injuries are grouped by body part now, rather than injury category, and the combination codes have been created for commonly occurring symptoms and diagnosis and etiologies and manifestations to help reduce the number of codes needed. However, that brings a new set of challenges for us, because the combination codes include a number of diagnoses, which means that the documentation must be there to support all of the diagnosis within that combination code. Home health will no longer code aftercare, but if in the case of a fracture, would actually code the fracture, then add the 7th character. The clinician must be very certain there is documentation for the cause, and the code itself will now identify an acute fracture, the aftercare, or a complication. The urine intake department becomes very crucial. Really is going to be essential to assist that clinician in the field. Intake can no longer just copy what they see. They're going to have to get far more specific as to, in the case of wounds, knowing where, when, the length, size, site, and details. They're going to have to note laterality to make certain that there is congruity between laterality noted in the inpatient as well as into the next level of care. They're going to need to note whether a condition is acute or chronic. The coding specialists are required to have this level of specificity, this level of increased documentation in order to proficiently document the exact code that is needed to be on that claim. Otherwise, you run the risk of auto-rejection. And a clear example given by a CMS representative a few months back was if the acute care hospital has noted that the patient is left-handed, but the home health agency notes that the dominance is right hand, then this can be cause for an automatic rejection, thus delaying your reimbursement. So really, it's time to get into some really good habits. Laterality has been needed for years. Document specifically any ulcers, their site, the laterality, the very specifics of the type of ulcer, where it's located, the depth, etc. The documentation of non-pressure ulcers is even more complex, and specific documentation is going to be essential in that assessment. And that OASIS integumentary assessment needs to be congruent with the narrative statement of the clinician. The injury or disease and treatment identified in the care plan with progress in teaching and learning, we need those orders and goals to support why the clinician is in the home to provide the care, why it is skilled, what the individual is doing that is worthy of the reimbursement from the payer source. CMS is going to be looking, as they stated, for coding completeness and capturing of all impacting codes. This means more documentation, and the specificity is essential in that documentation. Now, the word documentation, which you're probably already tired of hearing, was mentioned over 70 times in ICD-10 guidelines. That's up from a few times in the ICD-9 guidelines. 70 times means that it's important. And CMS stated at a conference that the importance of consistent, complete documentation in the medical record cannot be overemphasized. Without such documentation, accurate coding cannot be achieved. So the code assignment is based on the documentation of the relationship between the condition identified through assessment and the care delivered. That has to be very, very clear. CMS has also identified that one of the goals for them is that in the future, once the dust has settled with ICD-10, we should be seeing the coding as the table of contents for a clinical record. And from that coding, we should know roughly what that assessment should look like, and also what the overall treatment has been or will be for this patient with the expected outcomes. So gone are the days of writing a CVA. ICD-10 is going to require that for that CVA, we know the type of CVA, the artery involved, and whether it is thrombolic or embolic. Accurate coding depends on the clinician. We need the information. If we do not have the information, then we're going to have to send queries. Queries can slow down ultimate coding. The assessing clinicians required to complete all M items. Clearly, the regulation identifies only one clinician completes the OASIS assessment. The clinician has been granted the ability to actually collaborate with physical therapy and also to collaborate with coding specialists. But they cannot leave OASIS items blank to be completed by anyone else. We once worked with an agency that actually attempted, when we first came on, to leave all of the functional items for physical therapy to complete and wanted to leave all coding items for a coding specialist to complete. Neither is legally allowed. So the clinician must complete the assessment, including putting in the narrative description for M1010, 1016, 1020, and 1022. The coding specialist can then make the recommendation for the assignment of the alphanumeric ICD-10 complete code related to the diagnosis, but could not complete these without the clinician putting in that narrative description. So let's move on from our introduction to Chapter 1, and Elizabeth's going to take over from here.
All right, thank you for joining us, everyone. We're going to start first with Chapter 1, which is on infectious and parasitic diseases. Now, as with every diagnosis, you need to remember that you have to be certain that the clinician has physician confirmation of the conditions being addressed, that the conditions are under active treatment, and information regarding whether an infection is systemic or localized. Now, when you're documenting bacteremia, bacteremia is a systemic infection defined by positive blood cultures only. If the physician documents bacteremia versus sepsis, you must contact the physician for clarity. Symptoms such as tachypnea, tachycardia, and fever would indicate the presence of bacteremia in your patient. Again, you must know the source of your sepsis. Now, when we move on to C. diff, it may be coded if the infection is still present and the patient remains under active treatment. Does your patient remain symptomatic? Do they have a diarrhea still or a fever? Are they still suffering from abdominal cramping or loss of appetite? Are you teaching symptom management? Are you talking about the principles of staying hydrated with hydration teaching? Are you teaching medication adherence to make sure that they keep taking the medication to get rid of the C. diff infection? And are you teaching infection control precautions for caregivers for this infectious disease? Now, for hepatitis, we need to know several things in order for the coding specialist to code this promptly. You need to document if it's acute or chronic. What's the etiology? Is it alcoholic? Is it drug-induced or viral? And if so, what's the specific type? And do they have any related diagnoses as a result of the infection, such as cirrhosis? And is this actively addressed in the plan of care? Documenting for HIV, it's extremely important that you have very specific, very accurate documentation in order for your coding specialist to code HIV. Coding guidelines require coding of confirmed cases of HIV or AIDS only. You must have written confirmation of the patient's diagnosis. It's not acceptable just to have verbal confirmation and be able to code from that. Asymptomatic HIV cannot be used in either 1010 or 1016, as it will code to a Z code, which are status-only codes. That's pretty much the equivalent of our current V codes. And you need to be aware of your state's privacy laws.
I noticed also, Elizabeth, that one of the notes that I had made was that you have to have a diagnosis, to have a diagnosis of AIDS, you must have at least one of the 21 AIDS defining opportunistic diagnosis and a T cell count of 200 cells or less, and the normal being 600 and over. So in addition, so we need that, plus we need anything regarding the state regs then too.
Right. You would have to have very specific information. You would have to fall under the definition of AIDS, as Susan elaborated on. So obviously, if you don't have that specific information, you must contact the referring physician and make sure you get that information, and then be very aware of what your state privacy laws are, as many states don't allow you to code either HIV or AIDS.
And this would explain why at times we don't do that and we get questions then later.
Right, yes. There are states that just don't allow you to code either, or there are some states that will allow you to code AIDS if it's been confirmed, but never just the HIV positive status. Now, when you're documenting in Chapter 2 for neoplasms, it's become much more complex in ICD-10. Again, specificity is key. Unspecified is not acceptable for coding purposes. We need to know, is it malignant or benign? And always remember, a mass is not synonymous with a neoplasm. So we need to know, has there been a surgery? Was the entire neoplasm excised? Is there further treatment planned, or is it completed? What specifically was done, and is more treatment planned? Now, for documenting neoplasms of the oral cavity and pharynx, in addition to those neoplasms, you must now also document alcohol abuse and dependence, the history or present tobacco use, exposure to environmental tobacco smoke, exposure to tobacco smoke in the perinatal period, and occupational exposure to environmental tobacco smoke. of respiratory intrathoracic, as I said, you need to obviously have all that information present. Leukemia or multiple myeloma, your clinician must document if the disease is active, in remission, in relapse, or is it resolved per the physician. And be specific as possible to your plan of care. Does your patient now have a gastrostomy and require enteral feeding? Do they have an implanted port for chemo? Is the respiratory system compromised? And if so, are they on O2? Or do they now have a colostomy or ileostomy? Now for Chapter 3, Diseases of the Blood and Forming Organs, we'll talk about anemia, which is a common home health diagnosis, and the specificity that is needed. If it's a blood loss anemia, did it occur post-op, or is it due to a chronic blood loss? Do they have anemia of chronic disease? If it's due to CKD, if so, what stage is it? If it's due to a neoplasm, if so, what's the site? For nutritional anemias, we need to know, is it an iron deficiency anemia? Is it due to inadequate dietary intake? If it's a vitamin B12 deficiency anemia, is it pernicious anemia? And if they have a folate deficiency anemia, was it dietary induced? Was it drug induced? If it was drug induced, what was the drug? You must state that it is due to a specific drug, such as Keppra. When documenting for Pancytopenia, you need to know, is that Pancytopenia due to chemotherapy, and if you have a patient with a malignancy? If so, you must note the specific chemotherapeutic drug. Or is the underlying cause even known? If so, you must note the specific chronic disease, such as HIV, leukemia, or MDS. Now, for your plan of care for patients with diseases of the blood, you must identify how specifically is the illness being addressed in your plan of care. If they have weakness, has PT been ordered? And do your responses to M1800 through M1890 reflect that need for PT? Will you be drawing labs? Is your patient going to have routine CBCs? And if you have a patient with injections, if you're doing Procrit, will you be monitoring those injections? We move on now to Chapter 4, which is endocrine. Now, we're documenting for diabetes mellitus. Diabetes now falls into 5 major categories. We have diabetes due to underlying conditions such as malignancies, malnutrition, pancreatitis, cystic fibrosis, or Cushing's syndrome. Do you have diabetes due to drug or chemical induced, such as due to steroids or thiazide diuretics? Do they have diabetes due to something else, such as a pancreatectomy? If it's type 1, if it's due to an autoimmune process or islet beta cell destruction, or known as idiopathic, juvenile onset, or ketosis prone. They have a type 2. Is it due to an insulin secretory defect? Is it not otherwise specified, or just they classify it as an insulin-resistant diabetes?
And I understand we have now over 80 codes for diabetes.
There are many, many codes for diabetes, have much more specific information required that we used to have. It's really great from a coding perspective. It's going to be a little bit of a learning curve for clinicians because so much more information is now required. The great thing about ICD-10 for diabetes is that there are now combination codes that include the type of diabetes, the body system affected, and the complications affecting that body system, all within one code. If the diabetes is not specified by the clinician, your coding specialist is going to default it to type 2. But if that's not what was noted on the inpatient claim, the home health claim can be rejected. That's why it's really important to have specific and accurate information for your patient. If the medical record indicates that the patient uses insulin, a code for long-term use of insulin must be added per coding guidelines. Now, if your physician documents uncontrolled, poorly controlled, or inadequately controlled, this will now code to diabetes with hyperglycemia in ICD-10. Previously, we could only code it as if the physician stated it was uncontrolled or out of control. Otherwise, everything coded to controlled. Now we have much more leeway when it comes to verbiage, where if they do state that it's poorly or inadequately controlled, we can now assign a code to reflect that. And new guidance for ICD-10 states we can no longer assume a relationship between osteomyelitis and diabetes as we did with ICD-9. The physician now has to state that there is a causal relationship between the two. Now for hypothyroidism, this is a diagnosis we see quite frequently. However, we very rarely see interventions in the plan of care. It's probably one of our most omitted diagnoses. To code hypothyroidism, we must now know the type, whether it's post-procedural, congenital, drug-induced, or due to an iodine deficiency, and you must document patient-specific interventions for the condition. You must note if the patient has lethargy, hair loss, intolerance to cold, bradycardia, and depression, how you're monitoring for those signs and symptoms, as well as doing medication monitoring. When documenting for nutritional disorders, the type of deficiency must be specified by the physician, whether it's a vitamin deficiency or a mineral deficiency. The clinician must be specific as to the plan of care, as labs cannot be the focus of care in home health. You must be addressing the underlying condition. If you have a patient who's morbidly obese or overweight, the clinician must confirm with the physician those diagnoses. The clinician may only calculate the BMI. She may not make the diagnosis. Now, in documenting for hyper and hyponatremia, the underlying cause must be noted, such as dehydration or SIADH. For document treatment, you must document whether there's medication, what symptom control you plan, and what the patient would do and what emergency measures they would take. For hyper and hypokalemia, again, you must document the underlying cause, if it's due to renal failure, if it's due to the use of diuretics or fluid loss, and how that imbalance is being treated. Are you teaching medication measures, symptom control, or emergency measures because it can become a life-threatening condition?
Okay, let's talk now about mental, behavioral, and neurodevelopmental disorders. And under this, we have a number of categories. In looking at mental health disorders, there are 11 blocks. We're only going to touch on some of those today, the ones that would be most likely seen in home health. Also listed in this category come anxiety and depression. Also, for ICD-10, please keep in mind that some insurers now require that if the primary diagnosis is going to be listed in this category, that a psychiatrist must be involved in overseeing the care of the medications that are being utilized. So you'll want to make certain, if you have certain insurers, that you're aware of this. Now, for specificity, since sleep pattern disorders seem to fall in a number of both organic and inorganic categories and psychological and physiological categories, please be aware that just noting that a patient has poor sleep patterns will not be adequate with ICD-10. When making that statement, it will be expected by most payer sources that they will see documentation that will identify how you arrived at that conclusion. So when is the patient sleeping during the day and night? When are they awakening? What is the level and quality of the sleep? Are they going to sleep at night on a routine schedule? Are they taking a routinely scheduled nap every day? What are they doing to mitigate sleep patterns? And is there any pain associated? And how is it impacting these sleep patterns? And the pain now will also require reasons, and specifically if it's related to psychological issues or with psychological factors. We see depression a lot in home health care, and the documentation of depression must come from the physician. Over the years, I've seen at times where agencies have really believed that if a PHQ-2 score was above 3, they could note depression, and they've attempted to do so. Clinical depression, though, is a medical disorder, and it must be stated by the physician, so it must be verified by that physician. However, when using a PHQ-2 validated tool, there should be protocols at your organization as to what the clinician would do if indeed there were scores above 3. Frequently, there are agencies that recommend that a mini mental status exam be done and a suicidal ideation evaluation be conducted, whether it be a Beck suicidal ideation score or a Cornell depression score. and their protocols require this to be completed or conducted. In typical depressive episodes, the physician should note whether they are mild, moderate, or severe. And no matter which they are, you can expect to see some levels of a depressed mood, loss of interest in activities and expressions of joy, and there will be reduced energy levels, usually complaints of fatigue and decreased activities, and just stating that life is no longer fun. We may see a lot of other symptoms. One of the experts in the area of depression, Dr. Benjamin Miller, who has done a significant amount of research in the area of depression, a lot of research with seniors. He is from the Colorado School of Medicine. CMS takes a lot of his information. He is one of the ones who recommended that there be a validated tool such as the PHQ-2 utilized in evaluating depression. However, as you know, under OASIS C1, it is not required by CMS. However, you will note that there is a question that said, did you use a standardized validated tool? So in looking at depression, we would also expect to see some areas of decreased concentration, poor inability to have an attention span, decreased self-esteem and ego strength, certain ideations of guilt and unworthiness, pessimistic views of the future, ideas of self-harm, disturbed sleep, and decreased appetite. Pessimistic views of the future make it very difficult to enable the patient to reach their optimal level of performance and taking over independently for their care because it's difficult to hone in on a goal that they would like to complete. And frequently in the integrated care model, it is stressed that we're looking for something that would encourage the patient to strive towards that level. So that's one of the tools in brief therapy that we use in dealing with depression so that we can help to mitigate some of those pessimistic views of the future. One of the big changes in working with dual diagnosis, alcohol and drug dependence use and substance abuse are just that. No longer can the terms use, dependence, and abuse, and they're frequently have been used interchangeably, but no longer can that be so. The overall psychological world has identified that each of these are specific and unique to themselves. Alcohol dependence, drug dependence, and non-dependent abuse of drugs are classified in 3 categories, and there will be increased combination codes for them. We now need specifics as to the use of the specific drugs and alcohol. So if they're dual abusers or users or have dual dependency, we need to know that. And needing to know means how much of what drugs and how much alcohol is consumed when taking the drugs or later at what time. So we're looking at how much very specifically of what drug and what alcohol and how often. So again, no longer can you say the person has alcohol dependence or alcohol use. We have to know the specifics before that can be stated. Now, when the documentation refers to use, abuse, and dependence of the same substance, only one code will be assigned to identify the pattern of use based on the following hierarchy. And this is important. If the physician has identified that the patient is both a user and an abuser, and it's documented, the coder can only assign the abuse. If both abuse and dependence are documented, then it's dependence. And if it's all 3, use, abuse, and dependence, then it goes to the higher level of dependence. Now, another condition that we frequently see in home health that has now been identified as not identified as accurately as it should be, and there is movement from our psychology colleagues to educate the community more, is in the area of bipolar, both 1 and 2. While bipolar disorder is characterized by one or more manic episodes or mixed episodes and one or more manic depressive episodes, bipolar II is diagnosed after one or more manic depressive episodes and only one episode of hypomania. Now, the highs in bipolar II are called hypomania. Sounds a little oxymoronish, but they're not as high as bipolar I, which are true manias. And bipolar II is hard to diagnose, as we've discussed earlier, and it's sometimes misdiagnosed because as major depression, if hypomanic episodes go unrecognized or unreported, the patient usually only seeks help when they're depressed, or their loved ones really only seek care when they seem very, very depressed. So as a result, the hypomanic episode goes unnoticed and is then frequently missed. A psych nurse who's clinically skilled in working with the bipolar II and the actively depressed individuals. And your team might also include an OT. And for the bipolar II, this can be very helpful as well as for the depressed patient. Because with the psychotherapeutic nurse, we tend to use words as our tool and way to have individuals displace their feelings. But the occupational therapist tends to use activity. So with a depressed person, and remember, depression is usually a lot of internalized anger, we want to displace that anger into something that's more acceptable. Get it out, but get it out in an acceptable manner. And they frequently have activities that can assist in displacing that in a healthy manner. So it usually is a very good collegial team that works with the patient in having both a clinical nurse as well as an OT. Now, again, in noting insomnia, we have to note patterns of insomnia. The physician can no longer just say the patient has insomnia, silly as that may sound. So in order to state that, you must show evidence of it. Frequently, you're going to find that the patient's going to be asked to keep a log. And what you tend to find is frequently the patient will have times when they really did sleep well, and then may have had a couple of nights where there was insomnia. And so this helps the physician better understand. If they do have insomnia, then it would help them understand what was eaten before bedtime. Are they going to bedtime at a regular time? What are their activities and what's their stress level? What's going on in their life right now? And so is the insomnia situational? So is there something going on in their life that is a situation that's increasing the stress and thus increasing the insomnia? We see dementia, unfortunately, in all levels of care. And in ICD-10, we've put the dementia umbrella here because essentially we all need to understand just stating the patient has dementia won't cut it with ICD-10. We need to understand if they're having dementia, is it indeed due to the Alzheimer's? And one cannot draw the conclusion that if they have dementia, then indeed it's due to, and they also have Alzheimer's, that the two are linked. As Elizabeth was stating with some of the other disorders, we cannot jump to that causal conclusion. It must be noted by the physician. So, does this patient have Alzheimer's disease or frontal temporal dementia, which again would show some very different symptoms? Do they have dementia with Lewy bodies or Parkinson's disease dementia, a corticobasal degeneration or a progressive supranuclear palsy or a vascular dementia? And each of these have very different symptomatology. I once attended a seminar that was a half a day strictly on dementia and behaviors that are seen. So it's really our responsibility to list very clearly what symptoms are being seen to help support that diagnosis or to assist that physician in determining that specific diagnosis regarding dementia. Now, we're going to need to know the type in order to have the code, and we need that physician to note, again, as I said, is it a part of another disease? Are there behavioral disturbances? And here's where it's very important. Is the patient having auditory hallucinations, visual hallucinations, olfactory hallucinations? Very rare, but are they having them? That would very clearly give us some ideas regarding a very specific dementia. Is the patient wandering? When are they wandering? And does the plan of care indicate that teaching was directed to the caregiver regarding the patient's specific dementia needs? And have the OASIS corresponding questions been answered to reflect their mental status and the impact on learning? This is very, very important. Now let's move on to Chapter 6 and the diseases of the nervous system. Again, pain is the reason, if it's the reason for the encounter, and is sequenced as the principal diagnosis, then we better know what's being done for it, why, what's the cause, and we're going to have to assign the code for the specific site of the pain, followed by the appropriate code from G89. Now the documentation, it's not good enough to say they have pain. It's what type of pain are they having? When did the pain begin? What is the site of the pain? What is the frequency, the duration each time? And what mitigating relief strategies have worked? We also need to know if it's acute or chronic. And acute pain is now defined as lasting fewer than 3 to 6 months. And chronic pain, we need to know if they've had long-term chronic pain, what has been the level of tolerance of pain. So if indeed they're comfortable, if you could just get their pain 10 threshold down to a 3 where it's been for 35 years, they would be happy. We need to know that so that we're not struggling with them to get it to 1 when that probably is not going to happen. Now, in looking at the polyneuropathies and Guillain-Barre, we need to know if either of these are recent diagnosis, and are they acute or has this been long-term? How extensive, if there is numbing, how extensive is it? Is there tingling? Is there weakness in the limbs? When does that occur? Is there muscle pain? Is there cramping? In their nutritional patterns, is there difficulty swallowing? Do they have dysphagia? Is there any impact on bladder control? How extensive is the pain? Is there pain in the neck? Does it radiate to certain areas of the head? And is it continually in a certain site? Is there weakness in the eye muscles? And what about the sleep disturbances, and be very specific? Has there been noted tendon reflex involvement? Is it hypo or hyperreflexia? And is any of that evident? Now, for the patient with muscular dystrophy, how long have they had it? When was it diagnosed? What are the examples of the muscle weakness? Is there atrophy? Are they able to walk? How far, if they can? What aids might they have to have in order to ambulate? Are there joint contractures? Are there muscle spasms? How long do they normally last? When do they usually occur? What mitigating factors have been used? What balance issues might be seen? Is there a waddling gait? What about their facial expression? Are there drooping eyelids? Is ptosis aware? Is it immediately seen? Is there evidence of cardiomyopathy? And what kind of diet are they on? Has the physician been stressing seafood and green leafy vegetables with them? Is there evidence of pain? Again, how long, what kind, frequency, etc., what's been done to mitigate that pain? And has there been evidence of depressed mood or full clinical depression noted? Now, Parkinson's, we see a lot in home health, and we need to note then if there's evidence of tremors and pin rolling. And when you're looking at the pin rolling, look bilaterally. Is it both hands, or is it strictly seem to be confined to the more dominant side? Any slowed movement, any bradykinesia? any stooping or bending in the posture? And what about the balance? Is there a need for you to take a look at doing a tug or a Tonetti review? So again, at the beginning of your assessment, you have a more objective evaluation, and then when you're ready to discharge or throughout the episode, you're able to test again to see if anything that you have recommended is impacting that patient in a positive way. When the patient is ambulating, and this is important, are they able to also gesture when they ambulate? Or indeed, are they feeling so unbalanced that they're using their limbs strictly as a balance tool? What about speech? Is there lessening of facial expression? Are they getting that mask-like expression? And has their writing changed? Has it gotten smaller? We also see patients with Alzheimer's. And we need to know that when we're coding instruction, we're going to have to identify when an additional code will be necessary to identify when delirium is present, dementia with behavioral disturbance, or dementia without behavioral disturbance. So we're going to need to know the symptoms. It's considered mild if there are signs of cognitive deficits that are somewhat mild. How significant is the memory loss? Is it affecting both long and short-term memory? And give examples. The patient can speak about weddings of various family members, but could not recall that the daughter had given them an instruction yesterday afternoon. Is there any difficulty in word finding? And be sensitive to the patient who's struggling to find the words. Give them time to attempt to link words, because this is what you see in Alzheimer's, where the patient is going for a sounds-like word, a word that seems similar in their mind, and it's taking them a little longer to find that word. Are there visual spatial issues? And what about their reasoning and their judgment capability? Now, if it's moderate, you should see significant language involvement. There's difficulty with reasoning and judgment impairment. Sometimes statements they make just absolutely do not make sense. They may frequently have difficulty recognizing family members, and they have inability to learn new tasks and can experience very active hallucinations, frequently visual, many times auditory, rarely olfactory. Sometimes also they can have delusions, thinking that somebody they saw on the TV is really out to get them, and it can cause a lot of fear and concern. And we also need to know about their sleeping patterns and eating patterns. We're also going to be dealing with patients who have seizures, and so we need to know, besides the word seizure, what type of seizures, how frequently, when did they start, what might have been the inducement or the cause, and are the seizures full convulsive seizures, generalized or partial? Do they have a preceding aura usually before the seizure? What kind of aura? Is it a visual aura or an auditory or an olfactory? And in this case, olfactory might be more commonly seen. However, most patients have a visual aura. Are the seizures clonic or tonic, or are they both? And are they myoclonic with spasms? Any areas of atonicity? And this needs to be noted. And then has the family been obviously educated in seizure precautions? Okay, and that brings us to chapters 7 and 8. And Elizabeth, you're on with the eye and the ear and the mastoid process.
Yes, as we move on to chapters 7 and 8, we're going to talk about glaucoma. Now, for documentation for glaucoma, laterality must be noted, as well as whether it's upper versus lower eyelids on any eye condition. Well, ICD-9 requires that glaucoma be staged. ICD-10 now requires the specific type, the laterality, and the stage or severity. You need to know, is it open angle, primary angle closure, secondary, or other such hypersecretion glaucoma, and does the patient have episcleral venous pressure? When documenting the stage, we need to know whether it's stage 0, which is unspecified, 1 mild, 2 moderate, 3 severe, or 4 of an indeterminate stage. And if it's a borderline open-angle glaucoma, the level of risk must be noted. You must identify any underlying causal condition. Is it secondary to eye trauma or eye inflammation, or is it due to drugs or other eye disorders?
Elizabeth, I noted on our clinical documentation cues sheet that we also note under open angle that specific types like pigmentary, capsular, and residual, we need that specificity.
Yes, to accurately code it, you would need that specificity. So obviously you need to contact the patient's physician if all they have written is glaucoma. Also with cataracts, clinical classification of cataracts considers the zones of the lens in which the opacity appears, whether it's cortical, subcapsular, either anterior or posterior, and nuclear. And obviously opacities may overlap those zones. You need to note underlying contributory causes, whether it's systemic disease, such as diabetes, lifestyle factors, such as smoking, whether there were exposures to lead or UV light, and whether there is other intraocular disease, such as glaucoma or other retinal defects. And is the cataract age-related? You must note the form, or if it's drug-induced or secondary. Now for ear and mastoid hearing loss, you must document, is it central hearing loss, conductive hearing loss, sensorineural hearing loss, or is it mixed? Do they have sudden idiopathic hearing loss? If it's tinnitus, is laterality must be noted. Again, also with conductive hearing loss, laterality must be noted, and with sensorineural hearing loss. Respiratory systems. We're going to talk about frequently diagnosed circulatory diseases that we see in home health. For essential hypertension, it's no longer designated as benign, malignant, or unspecified for coding purposes, although certainly for diagnostic purposes it's still defined in that manner.
And if I can interrupt right here, this
Sure.
is where we noted yesterday that our cues still had that on there, so we are updating that, and we'll put the essential with heart failure or without heart failure on there.
Right, because although your physician will still, obviously designate it as benign, malignant, or they will just write essential hypertension for the cue that we're going to give you for your recommendations, we just need to know whether or not it's an essential hypertension or if it's related, there's a hypertensive kidney or heart disease. Now for the definition of an acute phase for treatment of an MI, under circulatory diseases, they have now shortened the definition of the acute phase from the 8 weeks that it was previously now down to only 4 weeks. Anything beyond the 4-week phase is now considered a history of MI. And coronary atherosclerosis codes are now combination codes that will now include the presence or absence of angina. As we said for hypertension, hypertensive disease is now classified into 2 broad types. This is probably the only where in ICD-10 where they got less specific instead of more specific. It's now classified into either essential or secondary hypertension. Essential hypertension refers to abnormally elevated blood pressure with no underlying cause, and it's often associated with age or have familial or genetic factors developed for disorder development. Diseases that are associated with developing hypertension obviously include obesity, sodium sensitivity, elevated renin levels, insulin resistance, and vitamin D deficiency. For the 2 types that we will now have available to us for coding in ICD-10, it will either be essential only, it will be hypertension with or without heart failure, and again, it must be your physician who documents that the heart failure and hypertension are related. We cannot assume a link between the 2 conditions just because both are present within the medical record. We have hypertensive chronic kidney disease with the CKD stages 1 through 4, or a stage 5 and end-stage renal disease. And for patients who have both hypertensive heart and chronic kidney disease with or without heart failure, we will add and identify the kidney disease stage. As with a lot of diagnoses in ICD-10, you must now use an additional code to identify any exposure to tobacco smoke, a history of tobacco use, or occupational exposure to environmental tobacco smoke, whether the patient has tobacco dependence or does tobacco use. For myocardial infarctions, in ICD-10, not only has the time period for initial treatment changed from 8 weeks to 4 weeks, but the definition of subsequent episode of care has changed from care related to the initial acute MI to care related to a new MI. Codes for subsequent episodes of care are now only used when the patient suffers a new MI during the initial 4-week period of the previous acute MI. And also new is the instruction to code any documented exposure to tobacco smoke or any history of current use or dependence on tobacco. Any ST elevation MI involves ECG evidence of ST segment elevation. Patients with STMI can develop Q waves, which indicate dead myocardium and irreversible damage. If they have a STEMI MI, the key terms to know is the patient has a coronary artery embolism, occlusion, rupture, or thrombosis, an infarction of the heart, the myocardium, or the ventricle, the transmural Q wave function, the ST AMI, and AMI with ST elevation. If they have a non-ST elevation MI, the key terms again are coronary artery embolism, occlusion, rupture, or thrombosis. It also be called an acute endocardial MI, a non-Q wave MI, and a non-STEMI MI results from partially blocked coronary artery and is diagnosed on the ECG, which indicates no ST elevation. In a non-STEMI MI, there's less permanent damage to the myocardium. For MIs, you must identify the episode of care, whether it's initial or subsequent. As we stated, the definition of subsequent has changed from being just for the initial MI to only if the patient has suffered another MI within 4 weeks of the first MI. You must identify the type, whether it's ST elevated or non-ST elevated. Identify if there's tobacco use, dependence, or remission. And you must identify the location of the MI, whether it was ST elevation of the anterior wall, was it of the left main coronary artery, the left anterior descending coronary artery, the ST inferior wall, or the ST left circumflex coronary artery. Now for late effects sequelae of cerebrovascular disease, as with ICD-9, there is no time limit as to when a late effect code can be assigned, such as for an subarachnoid hemorrhage affecting the right side or left side, an intracerebral hemorrhage affecting the right side or left side, and now with intracranial hemorrhage, there are more than 6 types. The cause of sequelae as non-traumatic would be cerebral infarction, intracranial or intracerebral hemorrhage, or a subarachnoid hemorrhage. You would identify the sequelae of the cerebrovascular disease, whether there's the presence of apraxia, ataxia, cognitive deficits, dysphagia, facial weakness, whether there's right or left dominant hemiplegia or hemiparesis, whether there's a paralytic syndrome, or whether the patient has speech or language deficits. And you need to know if the CVA was embolic, thrombotic, and what artery was involved. For respiratory diagnoses, for pneumonias, the most common cause is Streptococcus pneumoniae. You must have the specific cause of the patient's pneumonia in order to code pneumonia in ICD-10. You must identify the cause of any bacterial pneumonia with organisms such as E. coli, Haemophilus influenza, Mycoplasma, or Pseudomonas. And if it was Staphylococcus, is it due to methicillin resistant or susceptible? Or if it's strep, is it group B or another specified strep?
So we have to have that specific information.
Yes. To code anything that's bacterial or viral, you must have the specific bacterial or organism to code for pneumonias in ICD-10.
Okay, good to know.
COPD, it's now classified under unspecified bronchitis/chronic bronchitis. There are categories of unspecified or mucopurulent or other COPD, and a change in terminology in ICD-10 from obstructive chronic bronchitis, it's now referred to as chronic obstructive pulmonary disease. You must identify the type. If it's non-acute bronchitis, is it chronic, mixed simple, mucopurulent, or simple? And with chronic obstructive pulmonary disease, is there an acute lower respiratory infection with exacerbation, or is it unspecified? For asthma, ICD-10 requires that asthma be designated as mild, moderate, or severe And then you must differentiate it as uncomplicated, with acute exacerbation, or with status asthmaticus. Chronic obstructive asthma is no longer listed in the category for asthma, as it has now been moved to the category of chronic obstructive pulmonary disease, where it belongs. Again, you must identify the types, whether it's mild, moderate, persistent, severe persistent, or other, and you must identify all related complications. We move on now to Chapter 11, which are diseases of the digestive system. For general documentation requirements and changes, we will have the designation of additional conditions as acute or chronic. There are now combination codes requiring more specific documentation of complications related to certain conditions, and there's greater specificity related to intraoperative and post-procedural complications. If you have a patient with a gastrointestinal ulcer, GI ulcers may be caused by Helicobacter pylori infection and by some medications. Excessive alcohol use also predisposes individuals to ulcers of the GI tract. You must now identify the site, whether it's duodenal, gastric, gastrojejunal, and peptic, identify it as chronic or acute, and identify any complications present, such as hemorrhage or perforation. If you have a patient with regional enteritis, Crohn's disease is now considered an immune deficiency state with chronic inflammation and thickening of the GI tract. Complications include bleeding, fistula formation, abscess formation, and obstruction. We must now identify the site, whether it's of the small or large intestine or both, and we must identify any complications, whether the patient has abscesses, fistulas, intestinal obstruction, or any rectal bleeding.
And Crohn's disease remains a case mixed diagnosis, does it?
Yes, it does.
Okay.
For ulcerative colitis, it's treated as an autoimmune disorder, and stress is often a factor with exacerbations. As with regional enteritis, we must now identify any complications, whether the patient has an abscess, a fistula, an intestinal obstruction, whether there's rectal bleeding present, or if there's other specified or non-specified complications. Some components that help distinguish ulcerative colitis is that it's nearly always in the rectum, and common symptoms are bloody diarrhea, rectal urgency, and tenesmus. Fistula and sinus tracts are rare, but are common in Crohn's disease.
And this is another case mixed diagnosis, and once again stressed that we really need to have the documentation and show why we're deserving of additional dollars to care for a patient with this need, so that we don't keep losing the case mix as we've been doing year after year.
Right, because agencies fail to properly document care they're providing and use diagnoses codes that, although they may be addressing, their documentation was poor. And as years have gone on, CMS is taking more and more mixed diagnoses away because they are overused and incorrectly used. Now, for irritable bowel syndrome, it's just a common non-inflammatory bowel disease characterized by abdominal pain and cramping with bowel movements. And now it's noted to be with or without diarrhea, as the codes are now different for each. For patients with chronic hepatitis, it's defined as lasting longer than 6 months. Common symptoms are jaundice, anorexia, and fatigue, but we now need to know for our coding specialist if it's chronic, autoimmune, or chronic lobular, or chronic active, and if ascites are present. For unspecified hepatitis and toxic liver disease, you must identify the liver disease with manifestations such as cholestasis, fibrosis, cirrhosis, or hepatic necrosis with or without coma. If the condition is due to a drug, you have to know which drug or toxin, plus note the intent, whether it was accidental, assault, intentional self-harm due to underdosing, or if the circumstances were undetermined.
And this is new this year too, right?
Yes, this is new this year. So
something to really keep in mind. We've got to know what the intent was.
Right. For cirrhosis, if it's biliary, is it primary, secondary, or unspecified? If it's the liver, is it not due to alcohol, but it may include cryptogenic, macronodular, micronodular, or the mixed type? Is there fibrosis or sclerosis alone? We move on now to Chapter 12, which is documentation for skin and subcutaneous tissue.
And one of the areas where we have our most queries.
We have our most queries before ICD-10. We're going to have many more queries now with ICD-10 because nowhere in ICD-10 are the changes more apparent than in this chapter. As with all other chapters, diagnoses must be confirmed by the physician. As per ICD-10 official guidelines for coding and reporting, for the depth of non-pressure chronic ulcers and pressure ulcer stage codes, code assignment may be based on the medical record documentation from clinicians who are not the patient's provider, since this information is typically documented by other clinicians involved in the patient's care. However, and this can't be stressed enough, the associated diagnosis must be documented by the patient's provider.
And provider in this case, as CMS has determined, provider means physician.
Correct. It's the patient's, anybody who's legally responsible for care for that patient within their state's guidelines. Now for abscesses, this is kind of exciting for coding specialists, probably not so much for clinicians, but we now have cutaneous abscesses are coded separately from cellulitis in ICD-10. Previously in ICD-9, they were combination codes. Now they are coded separately. An additional code is required for the infectious organism if known, and as with any other diagnosis in ICD-10, laterality and greater specificity are key features. When you're documenting abscesses and cellulitis, you need to make sure your response to M1350 is 1, yes, in a patient with an abscess or cellulitis currently under treatment. An abscess is not a surgical wound unless it is completely excised, and an IND does not constitute surgery for either OASIS or coding purposes, and that's important to remember. For dermatitis, with increased specificity comes an increased number of available codes. Nowhere is that more apparent than with dermatitis. It's not a condition that we see a lot of, but boy, ICD-10 has us ready in case we do. We now need to know what type of dermatitis your patient has. Is it atopic, seborrheic, allergic contact, irritant contact? Is it due to substances taken internally? And if so, is it due to drugs or to food?
And do we need to be specific regarding the drugs and the food?
The food we do not, the drugs we do. There are combination codes. If your patient has a reaction due to a specific drug, you need to identify that drug. For pressure ulcers, this is really a great addition for home health because pressure ulcer codes are now a combination code with both site, stage, and laterality, all wrapped up into one code. This allows greater specificity in coding and paints a much better picture of your patient and the care you're providing.
That's good to see, and that kind of supports what CMS is stating, as eventually the coding will be seen as the table of contents of
Absolutely.
Of the record.
We are now able to capture every ulcer that you're taking care of. Now you need to be sure to respond accurately to M1306, indicating that your patient has a pressure ulcer. With OASIS C1, you need to document the number of pressure ulcers currently present and their stage on the day of assessment in M1308. Like with coding, specificity when answering M1320 is key when you're reporting your most problematic observable pressure ulcer, because an incorrect response in 1324 impacts not only risk adjustment but reimbursement as well. Now for chronic ulcerations, this is where the most specific information is now required. It's when you're coding non-decubitus ulcers in ICD-10. You must now know how much breakdown has occurred within the wound. You have to identify whether that breakdown is limited to breakdown of the skin, whether there is now fat layer exposed, whether there is necrosis of the muscle, or whether there is necrosis of the bone. We have to have this information in order to code chronic ulcers.
I can see queries flying regarding this.
Queries will be flying when it comes to any kind of ulcer that's not a D-cube. For D-cubes, they now have combination codes from L89, as we stated, that identify both site and stage. If the pressure ulcer is documented by the physician as healing, it is assigned the appropriate stage code based on the documentation in the medical record. However, if the pressure ulcer is documented as quote-unquote healed by the physician, it is not coded. This applies to stage 3 and stage 4 D-cubes as well. We know the WOCN guidance states for OASIS purposes that stage 3 and stage 4s never heal, they only close. But this is where you need to remember OASIS guidelines and coding guidelines are not the same. So while you may have a response on your OASIS that indicates your patient has a 3 or 4 ulcer that is closed, if the physician calls it healed, we would not be able to code it.
Good to know.
Moving into Chapter 13 for musculoskeletal. Again, with general documentation guidelines, you must have good information from your patient's physician. If your patient has just returned home from an inpatient stay, you must have the discharge summary to confirm those conditions that were identified in treatment during their hospitalization and will continue to require ongoing care. If your patient was referred from an outpatient setting, you must obtain a current history and physical, as well as office visit notes relating to their admission to home care.
I can see queries going regarding this.
Absolutely. We have to have office visit notes that support their need for home health and to support the diagnoses that we are going to assign. This is going to have to be part of your intake process. There will be no exceptions. Lack of specific information impacts not only reimbursement, it impacts your outcome measures as well, and it is just absolutely required with ICD-10. It's what CMS expects to see.
And this is part of that expanded role of the intake department we were talking about, their assistance with that clinician to gather this information for
Absolutely.
them.
They're going to have to work as a team to get the information that is needed to code. For requirements, with the change from ICD-9 to ICD-10 comes major changes in how all diagnoses are coded. Both the site and laterality must now be documented in order to be accurately coded. Previously, we had no laterality, so this really is a nice addition. For musculoskeletal system, the site represents the bone, joint, or muscle involved. And when there are multiple sites involved, you would document all sites involved, whether under active treatment or not, i.e., OA of multiple joints. If you have a patient where you're addressing problems with their knee because they have OA of the left knee, but they also have OA in their hips and shoulders, you would document OA of multiple joints, although you are only providing care to one of those sites. And again, there's now specificity as far as laterality. Rheumatoid arthritis has really been expanded. There previously was one code, 714.0 and ICD-9, but there are now multiple codes specifying not only the site, but involvement of other organs and systems as well. There are now codes available for RA with or without rheumatoid factor, rheumatic heart disease, rheumatic nodules, and rheumatoid bursitis. When documenting gout, you have to have so much specific information for gout. I know that kind of seems overkill, but really the musculoskeletal is where we see most of the changes. It's much more specific. There's now codes for idiopathic gout, lead-induced gout, drug-induced gout, gout to renal impairment, or other secondary gout.
And I was glad to see they moved it into the proper chapter.
Right. It now is where it belongs in ICD-10. Documenting arthritis, codes still continue to be available in ICD-10 as in ICD-9 for unspecified codes for quote-unquote arthritis. The expectation is that coding will be much more specific for this condition because codes are available for multiple types of arthritis, including but not limited to monoarthritis, allergic arthritis, osteoarthritis, polyosteoarthritis, post-traumatic arthritis, secondary arthritis. In addition to the specificity as to the type of arthritis, there are now specific codes for laterality as well. When you're documenting for knee derangement, you need to know if the derangement is of the lateral or medial meniscus. Is it due to an old tear or injury or due to a current injury? And is it of the anterior horn or posterior horn? And are loose bodies present? Because that will affect our code assignment. When documenting for systemic connective tissue disorders, systemic lupus documentation requires the underlying cause, such as drug-induced, if known, as well as any organ or system involvement present. And Sjogren's syndrome now requires documentation of any organ or system involvement if present as well. When documenting for spinal spondylosis, this is where we see really great specificity. If you have arthritis or osteoarthritis of the spine documented, You now must have additional documentation detailing any myelopathy or radiculopathy if present, as well as the specific vertebrae involved, including occipito-atlantoaxial region. Is it cervical, cervicothoracic, thoracic, thoracolumbar, lumbar, lumbosacral, or sacral and sacrococcygeal?
So, Elizabeth, are we going to need to have cervical and then the number of the vertebrae, or will cervical be sufficient?
We would need to know what vertebrae are involved because it may entail coding more than one code depending on the region that's involved.
Okay.
Also, same with disc disorders. Disc disorders, including displacement and degeneration, are coded with more specificity than ever. If your patient has a cervical disc disorder, you must now specify whether it's the high cervical region, the mid-cervical region, or whether it's the cervicothoracic region. Osteoporosis has greatly expanded. It's more specific than ever, detailing now if it's age-related, if it's age-related with current pathological fracture, if it's age-related without a current pathological fracture, whether it's drug-related with current pathological fracture, or drug-related without a current pathological injury or fall, that the fracture occurred because of an underlying disease process.
And here's where we would see those, the seventh character used here to delineate the coding pathological or stress-related fracture.
Yes.
So it's going to tell us specifically which it is or what it is.
Right.
Okay.
Osteomyelitis documentation includes now whether it's acute, subacute, chronic, chronic multifocal, chronic with draining sinus, which is new and really a great addition, or unspecified, and the site of the osteomyelitis as well as the laterality. Is the right shoulder, left hand. But unlike ICD-9, there is no presumed link between diabetes and osteomyelitis. The physician now must state the underlying cause if known as per official coding clinic guidance for ICD-10. We no longer have that assumed causal relationship between those two conditions, and you must ask the physician what the underlying cause of the osteomyelitis is.
And so if he would state it's bacteria, do we need to know the type of bacteria?
Yes, if it's bacterial, we would need to find out the organism that was involved and code that as well.
Okay.
Now, for plan of care and illness, it's important to document not only how your illness is impacting the plan of care, but also how you as the clinician plan to address it. Does your patient have pain, and do your responses to M1240 to 1242 reflect the severity and frequency of their pain? And do you have interventions for pain management in your plan of care? If it was not ordered by the physician, have you requested PT to address your patient's condition? Do your responses to M1800 to M1890 reflect this need as well? We move on now to Chapter 14, which are diseases of the GU system. For general documentation, the most significant changes related to documentation for diseases of the genitourinary system include documentation of the severity or status of a disease, whether it's acute or chronic, as well as the site, etiology, and any secondary disease process. The provider documentation should clearly specify any cause and effect relationship between medical treatment and a genitourinary disorder, such as a post-catheterization urethral stricture. The documentation should specify whether a complication occurred intraoperatively or postoperatively, and many codes now require more specific documentation of the site, including laterality, right, left, or bilateral, for paired organs and the extremities. For cystitis, as you know, it's an inflammation of the bladder. It's most often caused by a bacterial infection of the urinary tract. It can also result from a reaction to certain drugs, radiation therapy, irritants such as a long-term use of catheters, or as a complication of another illness. Documentation in the medical record needs to specify the type and cause of the cystitis and identify any infectious agent or organism such as E. coli. ICD-10 now requires documentation of cystitis as with or without hematuria. As you can see, we now have multiple choices for cystitis. We have to identify whether it's acute with or without hematuria, chronic with or without hematuria, whether it's due to radiation, whether it's trigonitis, or another specified type, all with or without hematuria, and we must add an additional code to identify the infectious agent. Hematuria really has found to be a far more important symptom in the diagnosis and treatment of renal diseases than previously thought. When it's recurrent and persistent and diagnosed with several various glomerular diseases, there are now combination codes available in ICD-10 to report the condition much more accurately than it was possible with ICD-9. If your patient has hydronephrosis, it's a condition in which the kidney's urine collecting system becomes dilated, usually due to an underlying illness or medical condition. Distension of the kidney with urine is caused by the backward pressure placed on the kidney when the flow of urine is obstructed. Obstruction or blockage is the most frequent cause of hydronephrosis, but the condition may also be congenital, and it may also be caused by trauma, neoplastic disease, the presence of calculi, inflammatory processes, or due to surgical procedures, and documentation of the etiology is essential for correct code assignment. Obstruction can occur anywhere from the urethral meatus to the calceal infundibula, and the physiological effects depend on the level of obstruction, the extent of involvement, the patient's age at onset, and whether it's acute or chronic. And hydronephrosis can be unilateral, involving just one kidney, or bilateral, involving both, although ICD-10 does not require laterality for this specific condition. For acquired hydronephrosis, we need to identify the cause. Is it with infection? Is it with renal and ureteral calculus obstruction? Is there a ureteral stricture? Is it an other specified hydronephrosis, or is it unspecified? We just don't know the cause, and we can't get that information. If you have a urethral stricture, and that can be resulted from various causes and present a range of manifestations. Causes can include trauma, is an adverse effect or complication from medical treatment, an inflammatory or infectious process, or due to a malignancy. Most are the result of trauma to the perineum, such as a traumatic catheter placement or removing of a chronic indwelling Foley. When you have a urethral stricture, you need to identify the cause. Is it post-infective? Is it post-procedural? Is it post-traumatic? Is there another specified cause, or is there just an unspecified cause? We don't know why it happened. To have your coding specialist correctly code this, we must know the patient is a male or female. And if it's a male who has post-infective, post-procedural, or post-traumatic, you must identify the site of the stricture, such as the anterior urethra, the bulbous urethra, the meatus, the membranous urethra, or if it's an unspecified site. And if you have a female who has a post-traumatic stricture, we need to know if it was due to childbirth or to an other specified trauma.
This is a lot of additional information, Elizabeth.
There's a tremendous amount of additional information. GU has a lot of additional information that we previously didn't have, and musculoskeletal also probably are the two categories where we see a lot more specificity than we had previously. Now, if you have a patient who has a vesicoureteral reflux, that's the abnormal flow of urine backing up into the ureters. It can be unilateral or bilateral, and documentation of laterality is necessary for code assignment in ICD-10. It can damage the kidneys, and when this occurs, it's referred to as reflux nephropathy. ICD-10 requires documentation indicating the presence or absence of damage to the kidneys caused by that reflux of urine. And ICD-10 also captures the presence or absence if the patient has hydroureter. The vesicoureteral reflux with reflux nephropathy is not the same as reflux-associated pyelonephritis. The two conditions are coded differently, and the two conditions must be clearly differentiated in the documentation. To identify the type and presence of reflux, if it's with reflux nephropathy, if it's with hydroureter, is it bilateral, unilateral, or unspecified, although we would not use this in home health? Is it without hydroureter? Is it bilateral, unilateral? Again, we would not use unspecified. Or is it without reflux nephropathy? We would not want to use unspecified unless we absolutely could not get more specific information.
And that would be a flag.
That would be a red flag to CMS, yes. If you have post-procedural acute or chronic kidney failure, official coding guidelines, IB-16, state that code assignment is based on the provider's documentation of the relationship between the condition and the care or procedure. The guideline extends to any complications of care, regardless of the chapter in which it's located. It's important to note that not all conditions that occur during or following medical care or surgery are classified as complications. There must be a cause and effect relationship between the care provided and the condition, and an indication in the documentation that it is indeed a complication. You must query the provider for complication clarification if it's not clearly documented, because the physician has to be the one to state the causal relationship. Postoperative acute renal failure is a serious complication resulting in prolonged acute care stays, higher mortality. Key terms that you would find in documentation for post-procedural acute or chronic kidney failure include post-op chronic renal failure, post-op acute renal failure. The provider documentation should also list any type of kidney disease that patient may have. For additional information on CKD, the stages of CKD and ICD-10 are based on severity. The severity of CKD is designated by stages 1 through 5. Stage 2 equates to mild CKD. Stage 3 equates to moderate CKD. Stage 4 equates to severe CKD. And end-stage renal disease is assigned when the provider has documented end-stage renal disease, or if they have identified stage 5 but the patient is on hemodialysis. If they identify both a stage of CKD and ESRD, both are documented, you assign the end-stage renal disease only. If you have a patient with chronic kidney disease who has a kidney transplant status, some patients who've undergone kidney transplants still have some form of chronic kidney disease because the kidney transplant does not always restore full kidney function, and therefore the presence of CKD alone does not constitute a transplant complication. You would just assign the appropriate codes for the patient's stage of CKD and the kidney transplant status as per provider's documentation. If a transplant complication such as failure or rejection or other transplant complication is documented, then that should be represented in the code selection. And if the documentation is unclear as to whether the patient has a complication of their transplant, you must query the provider and get that clarified.
And we tend to see this for a lot of patients who are in the Pittsburgh area where there's a lot of kidney transplants that are performed. So it's really good to know, Elizabeth.
Now, if you have CKD with other conditions, patients with CKD obviously often suffer from other serious conditions, most commonly diabetes and hypertension. The sequencing of the CKD code in relationship to codes for other contributing conditions is based on coding conventions. ICD-10 continues to presume a cause and effect relationship between hypertension and CKD and classifies chronic kidney disease with hypertension as hypertensive chronic kidney disease. This has not changed from ICD-9.
So something that hasn't changed.
Right. There are a few things that haven't changed. This is one of them. Now we move on to our final couple of chapters, 18 and 19, which are symptoms, signs, ill-defined conditions, injury, poisonings, and external causes. For general documentation, the most significant changes related to documentation for symptoms, signs, and ill-defined conditions include site specificity for laterality for some signs and symptoms, such as localized swelling, masses, or lumps of the upper or lower extremities. More detailed descriptions of signs and symptoms, such as malaise and fatigue, which now includes specific codes for neoplastic-related fatigue or weakness. And specific identification of test results, such as abnormalities of plasma proteins, which include specific codes now for abnormality of albumin and globulin and alpha-fetoprotein. The most significant changes related to documentation for injuries, poisonings, and external causes include that there are now separate codes that are required for each injury unless a combination code is available. As same as with ICD-9, traumatic injury codes are never used to report normal, healing surgical wounds or complicated surgical wounds. Codes for adverse effects, poisonings, underdosing, and toxic effects are now combination codes that include both the substance taken and the intent. There is no additional external cause code reported with those codes. The vast majority of injuries to paired organs in the extremities now require documentation of the organ or extremity as the right or left. The fracture classification systems now include the Neer, Gastillo, and Salter-Harris, and fractures require seventh character extensions, but these extensions differ from those used for other types of injuries. For use of symptom codes when you have a definitive diagnosis, assignment of a sign or symptom code with a definitive diagnosis is dependent upon whether the symptom is routinely associated with the definitive diagnosis or disease process. When the sign or symptom is not routinely associated with that definitive diagnosis, a code may be reported in addition to related definitive diagnoses, such as the various signs and symptoms associated with complex syndromes, but the definitive diagnosis will always sequence before the symptom code. When the sign or symptom is routinely associated with a disease process, such as edema in a patient with CHF, you do not assign the sign or symptom code unless instructions for the category, subcategory, or the code itself state that the sign or symptom should be reported additionally.
And I've noticed that with one of our clients, I noticed recently there was questions regarding something like that. In fact,
Right.
I think that was the example given.
Yeah, agencies tend to want to code the signs and symptoms while they are when they're inherent. For coding guidelines, you never code something separately that's inherent to the condition. For abnormality of gait, in ICD-10, codes for signs and symptoms related to walking and gait now describe conditions more specifically as an ataxic gait, a paralytic gait, or unsteadiness on the feet. There are also codes for difficulty walking, as with an ICD-9, and other specified abnormalities of gait and mobility, and unspecified gait and mobility. Your therapist would identify the condition. Is it difficulty walking? Do they have a joint disorder that has not been surgically addressed? If so, it falls under difficulty in walking. If it does not fall into that category, it's a gait abnormality. And from there, your therapist has to identify, do they have an ataxic gait, a paralytic gait? Do they have unsteadiness on their feet? Or is it an other abnormality of gait and mobility? In home health, we have no reason to use unspecified abnormalities of gait and mobility because your therapist has gone out there and done an assessment of gait deviations. Now, for localized swelling masses and lumps, they are assigned when the documentation does not support a more specific diagnosis. In ICD-10, if your patient has an intra-abdominal and pelvic swelling mass or lump that's specific to the intra-abdominal and pelvic regions, it would not be reported if it's a superficial swelling mass or lump localized to the skin and subcutaneous tissue of the abdomen, unless otherwise indicated in the alphabetic index. They are now coded separately. There's a separate category for reporting localized swelling, masses, and lumps of skin and subcutaneous tissue, and those codes are specific to the site where that swelling, mass, or lump is. And careful review of the documentation is needed to ensure that the most appropriate code is assigned. You need to identify the site. Is it of the head? Is it of a lower limb? And if so, is it the right, the left, or is it bilateral? Is it of the neck or trunk? If it's an upper limb, again, is it right, left, or bilateral? If it's an unspecified site, we would not use that in home health. Obviously, if we're addressing something in the plan of care, we know where it's located, and we would never use an unspecified code. Edema, the excess accumulation of fluid in cells and intracellular tissues. It can be due to a number of causes, but it's a significant symptom, and when documented as such by the physician, it may be reported as an additional diagnosis. Again, if you have a patient who does not have CHF but has, localized or generalized edema, and you're addressing in your plan of care, you would code this sign and symptom in the absence of a definitive diagnosis. Now, for traumatic fractures, this is where it has totally changed from ICD-10 from ICD-9 for home health. Some of the main guidelines for coding fractures are that fractures are not indicated as open and closed are considered closed. If it's not indicated to be displaced or non-displaced, we would consider it to be displaced. And when there are multiple fractures, a separate code is required for each, and the provider should be asked to list fracture diagnoses in order of severity. So if you have a patient with more than one fracture, you have to get your physician to give you the severity of those fractures. You cannot make assumptions. And there's initial versus subsequent encounters for fractures that are assigned seventh character extensions.
And I was interested to see that there are distinctly different seventh character extensions for closed traumatic fractures as opposed to open fractures. So each have their own extensions.
Each has their own extensions, and obviously, if you have an open fracture, it's highly unusual, but if you do, you need to make that clear in your documentation because the coding is different. If you have a patient who has a fracture of the neck of femur, which we see very often in home health, there are 6 subcategories for fractures of femur. Fractures in most of these subcategories are further subclassified with additional information, as to fracture site and or fracture configuration and type, and whether it's transverse, oblique, or comminuted. You're going to identify the site of a femoral fracture. Is it the neck? If so, is it the base of neck, epiphysis? Is it intracapsular, mid-cervical? Is it of an other unspecified site or unspecified part? Is it of the head? If so, is it articular? Is it of the other specified site, or is it an unspecified part and you could not get more information? Is it pertrochanteric? If so, is it apophyseal? Is it the greater trochanter, the intertrochanter, lesser trochanter, or is it an unspecified trochanteric site, or is it subtrochanteric?
So fracture of the femur just isn't going to cut it in ICD-10?
No, not at all. So if you write fracture of the hip, you can expect an automatic query from us. We should have it just go out automatically as soon as you write that down.
Yes.
You just need to know it's going to come right back to you. As we stated before, with fracture status, you need to know if it's displaced or non-displaced. Laterality, obviously we would never use unspecified. You know what hip they fractured, they know what hip they fractured. But you must identify the fracture, whether it's closed, and if it's open, it's the classification type 1 or type 2, type 3A, 3B, or 3C, or whether it's just an open fracture and you don't know the classification. We must identify the episode of care. There is a code for initial, although that would never be for home health. We will always be subsequent, and from there we will specify, is there delayed healing of the fracture? Is there a malunion? Is there a non-union? Or is it routine healing? It's healing as just as you would expect. But this is also where we would identify the sequela of a fracture, where previously we had a late effect code, where we would code like difficulty in walking, an abnormality of gait, and we would have a late effect of a fracture. Now it would be identified with this code, with the classification being a sequela. Now for open wounds of the extremities in ICD-10, there are 6 categories. Codes for open wounds are now specific as to site and type of injury, and additional codes must be required to be reported for any associated injuries such as laceration of nerves, major blood vessels, muscles, or tendons, and an additional code would also be reported if there was any wound infection present. You must identify the site of the open wound. Is it of the upper limb, which includes the shoulder to the finger, or the lower limb, which is from the hip to the toe? You now have to identify the type of open wound. Is it a bite and not described as a superficial bite because that would code separately? Is it a puncture wound? And if so, is it with or without foreign body? Is it a laceration? If it's a laceration, is it also with or without foreign body? Or if it's an unspecified open wound, you would need to contact your referring physician and ask him what the type of open wound is and how it occurred. And again, we would identify the laterality as right or left. We would identify the episode of care. In very rare instances, we could be the initial encounter. If the patient suffers a wound at home and the physician calls you and asks you to send out nursing to evaluate the wound and then report back to the physician, in that very rare instance, we would be the initial encounter. But for most all, we will be the subsequent encounter, or we would use the sequela if we find that the patient has some resulting deficit due to that wound. Now for burns, burns are now classified as chemical or thermal and then by depth and extent. If it's a chemical burn, we now classify them as corrosions, while thermal burns remain classified as burns. And a toxic effect code provides more information on the type of agent that caused the corrosion or burn and on the intent, whether it was accidental, intentional, self-harm, assault, or undetermined circumstances.
I find this part so interesting. As an addition for ICD-10.
I really like it. I think it's, it explains how because the burns are going to heal differently depending on what caused the burn. Mm-hmm. So, I think this is really interesting, and I think this is a great addition for home health. Again, you identify the type of burn. Is it a corrosion, which would be a burn due to acid, alkaline, caustics, or chemicals? Is it a thermal burn of any type except sunburn? And is that due to electricity, flame, heat, whether it's gas, liquid, or object, radiation, or steam?
And again, just so everybody's aware, the 4th character on the burn code would identify the degree of the burn. So this is why it's very important for us to know, because that's carrying, that code is actually telling that degree of the burn.
Right. We have to have that information. Again, we have to identify the site. If it's external, is it the eye or adnexa, or is it down to the internal organs? Again, laterality, right or left, we would never use unspecified. And obviously, as she said, we have to identify the depth. You have to have first, second, or third degree. We would never code something to an unspecified degree. We have to identify the extent of the total body surface area. This is not new to ICD-10. This was also required in ICD-9, and this information must come from the referring physician. Again, we must identify the agent and intent, how the burn occurred, what was the intent, whether it was accidental, intentional self-harm, was it due to assault, or were the circumstances undetermined. In poisoning, in ICD-10, there are now 4 general classifications of drug toxicity. Adverse effect is defined as a toxic reaction to a drug that was correctly prescribed and properly administered. Poisonings are defined as a toxic reaction to the wrong prescription or the wrong dose of a drug, or to a correctly prescribed drug that the patient took in combination with a non-prescribed drug or with alcohol. And a toxic effect is a poisoning from a substance that is non-medicinal in nature, such as alcohol poisoning, lead poisoning, or poisoning from heavy metals. New to ICD-10 is underdosing, which refers to taking less of a medication than was prescribed by the provider or less than the amount recommended by the manufacturer. Underdosing is never a principal or first listed diagnosis. The effect of the underdosing would be coded first.
Now, to me, that was very interesting as an addition, because though we've seen in the past in home health where a patient may not be taking all of their medication, there really was no place to really put that.
Right. We had no way to, something is exacerbated because your patient is supposed to be, they have the severe edema because they're supposed to be on Lasix, but they couldn't afford to pick up their prescription. Mm-hmm. Or they decided they didn't want to swallow those big pills, so they cut it in half and were only taking half, and you weren't going to make them take 2 halves. So we get we get every scenario for reasons why they don't take what they're supposed to take, but now we have a way to capture the effects of that non-compliance.
And that's really good for us to be able to do. It does paint that more conclusive picture.
Yes. Again, we will identify the drug and external cause. It's now a single combined code, and use an additional code to specify the drug reaction. As we said, whether it was an adverse effect, you would code first the specific adverse effect. Whether it's a poisoning, we would identify the external cause. Was the poisoning accidental? Was it intentional? Were they intending to harm themselves, or were they being harmed? Was it an assault? Or are the circumstances undetermined and we don't know how it happened? And we would code the specific toxic reaction due to the poisoning additionally. When we identify the drug and external cause for underdosing, which we discussed was taking less than prescribed or less than recommended, we would code the specific medical condition first resulting from the underdosing, and then the code for the underdosing.
Well, thank you, Elizabeth. You probably will have laryngitis now. But,
Yeah.
I hope this has been very helpful to everybody. Obviously, there may be some questions afterwards, but it certainly gives you a lot of information that you can now refer to and make your own notes and comments. If you have any questions, feel free to give Elizabeth or I a call or send an email. Emails are probably preferred. That way then we can share that, get a research done for you, and get the information back to you. What we've also done is created a clinical documentation cue card for you. Some organizations are making these front and back, and they're laminating them for you, so you certainly can ask for that to be done, or you may want to do it yourself. And what we've done is, because there have been so many changes and the depth of the documentation is so significant, we've taken some of the key areas and we've listed them for you. So that on the cue card, you could quickly see that for heart failure, is it systolic? Is it diastolic? We've got to know. Is it combined? Is it acute, chronic? What's it due to? If it's something other than that, then you need to note that. And it's just cueing you that this information is needed. If it's an MI, we need to know, is it ST elevation of the anterior wall? Is it left main coronary artery? What is it? And this is information that we didn't routinely get before. with a patient who had a myocardial infarct. We also need to know the length of time, and here's where that tobacco use comes into being, and we're going to need that information. Are they a tobacco user? What is their dependence level? Is it in remission? Are they using smoked tobacco or smokeless tobacco? For heart valve disorders and fibrillation and flutter, we've noted that. For respiratory failure, that too is noted, as well as angina. And again, just cueing you for COPD. Please remember, is that O2 continuous or PRN? Again, what type of COPD are we talking about? For the pneumonia, as Elizabeth had stated before, what is the organism? We've got to know that organism. And then again, also a type-wise, or was it aspiration or ventilation associated? For diabetes, what again is the type of the diabetes? What complications are involved? And is it controlled or out of control or poorly controlled? And remember, this is not from the patient's perspective. This is from the physician's validation. For glaucoma, very specifically, open angle won't cut it. We need to know what kind of open angle, primary, low tension, pigmentary, capsular, residual. And again, we made the cue card because we want to try to mitigate the number of queries, TDRs, that we expect by virtue of giving you some of this guidance here. This is just cueing you that these are the questions we're going to be asking if the information is not present. If it's anemia, what type of anemia is it? Very specifically. If it's cellulitis, what site? What's the laterality? What position on that limb? And again, if it's a pathological fracture, which bone is involved and what's the etiology there? And CVA, as well as depression, and we put obesity there also. Now we're going to make the change on hypertension. Now, Elizabeth, we're going to take off the unspecified benign and malignant and add then essential and secondary?
Right. We'll make it an essential and secondary.
Okay, so the essential will be with or without the heart failure.
Right.
Okay.
And chronic kidney disease.
Okay, so we'll get that on there. So we'll make those changes today, and we'll be shooting that updated cue card out to you, so you'll have that to rely on also. Again, if you have any questions, do not hesitate to send an email to elizabeth.clarke, CLARKE, @selectdata.com. And I believe I have, yes, at the back on the last slide, I have Elizabeth's email there. Elizabeth is our coding quality analyst, and she heads our audit team, and has newly been appointed as Director of Education. Congratulations, Elizabeth.
Thank you. Very happy to do it.
And we're looking forward to all of the education that she can provide. Elizabeth comes to the firm, has been with us for over a decade, but came to the firm with a very broad background in inpatient and pathology, as well as now her outpatient experiences too. Please, again, if there's any questions, let us know, and thank you very much for joining us today.
Thank you. Goodbye.